You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is October 17th, 2025. We will be doing our fellows lectures and doing core curriculum discussing aspirin allergy. This is presented by Dr. Manali Shah, an allergy and immunology fellow at Children's Mercy Hospital in UMKC.
Doing core curriculum today, so I like to pick topics from the Middleton's chapter that we don't encounter a lot in clinical practice. So I did hypersensitivity to aspirin and other NSAIDs today. Don't think we talked about this last year either, so definitely a good review, refresh for me. Okay, so let's just kind of dive right in. So there's different types of reactions to aspirin and NSAIDs. It's really based on the European classification. They divided both into acute hypersensitivity reactions and then delayed hypersensitivity reactions. With the acute hypersensitivity reactions, the symptoms are typically either respiratory, so that would be upper or lower airways, or skin manifestations, so urticaria, angioedema, and then some can have anaphylaxis symptoms as well. Within that acute hypersensitivity category, there can be patients who react to multiple NSAIDs, so that would be the cross-reactive type. Or there's just what we call a single drug induced, which is an IgE-mediated mechanism where they have symptoms of urticaria, angioedema, anaphylaxis to one type of NSAID within a chemical class of structures. There's also delayed hypersensitivity, and typically with other drug reactions, this presents 24 hours or even weeks later, can present with various organ or systemic manifestations, and these are typically T-cell mediated responses. So these are the 5 different categories that we'll kind of talk about each one. The biggest one, of course, is aspirin-exacerbated respiratory disease, but other ones to note: NSAID-exacerbated cutaneous disease, NSAID-induced urticaria, angioedema, single NSAID-induced urticaria, angioedema, anaphylaxis, and then single NSAID-induced delayed reaction. So the first 4 are going to be the acute hypersensitivity, and then of course the last one, like in its name, is the delayed hypersensitivity reaction. So this is a table not actually from Middleton's or the board review book. It's from one of the classification papers in Jackie, but I thought it was at least helpful just to kind of get bearing. So the type of reaction is on the left-hand side there, the 5 different categories I just mentioned. Talks about the main clinical manifestations of these reactions. So with aspirin-exacerbated respiratory disease, it'll typically be respiratory or nasal symptoms. With the NSAID-exacerbated cutaneous disease and NSAID-induced urticaria, angioedema, it'll typically be cutaneous symptoms. And then the single NSAID-induced urticaria, angioedema, anaphylaxis can have anaphylaxis symptoms. Again, talks about the timing of reactions. These are all acute reactions except the delayed one. And then if there's any underlying disease present. And then we'll kind of go on to all those, but I thought this was at least a nice broad overview. So this was the table, kind of just says the same thing, but this is from the Middleton's chapter. So again, it talks about the timing of reaction, the typical clinical manifestations, if these patients will be cross-reactive to other NSAIDs or if they could tolerate other NSAIDs. And just to kind of clarify again, the acute reaction typically occurs either immediately or up to 6 hours after exposure, and then delayed reaction is typically 24 hours or more after exposure. So let's talk, this is just kind of a picture of the different spectrum of diseases that can have NSAID hypersensitivity reactions. So the cross-reactive types are these 3, meaning if patients have a reaction to aspirin or an NSAID, that they'll probably have reactions to other NSAIDs as well, especially the COX-1 inhibitor. So we'll talk about each one of these in detail. We'll start with the aspirin-exacerbated respiratory disease, definitely the biggest chunk of this in the board review book, at least on this section. So overall definition, so aspirin and other NSAIDs can induce a hypersensitivity reaction in a population of asthmatic patients. These symptoms will manifest as acute dyspnea, rhinorrhea, nasal congestion. It's typically referred to as the aspirin triad. So this is patients who have chronic rhinosinusitis with polyps, moderate to severe asthma, and then do have a hypersensitivity reaction that occurs after aspirin or other NSAIDs. There are other names for this. The one that the board review book mentioned is Samter disease as well. So just to know the other names. I think also something that's interesting that the Middleton's chapter really emphasized was that these patients will have eosinophilic inflammation both in the upper and lower airways that's already present before even being exposed to aspirin or NSAIDs. So when they're exposed to these medications, that eosinophilic inflammation is just kind of made worse, but it's still there at baseline. So epidemiology is actually a lot more prevalent than I thought it would be, because again, I don't really see this even at our treatment hospital, but it is definitely more common in adult patients compared to pediatric patients. But the incidence, so number of new cases in adult asthmatics is 7.2%, but in patients who have severe asthma, that could increase to almost 15%. In patients who have chronic rhinosinusitis or nasal polyps, the prevalence was quoted up to 30%, but then the chapter discussed how there was more recent meta-analysis that the prevalence actually might be a little bit lower than that. So maybe about 10% in patients who have nasal polyps, and then about 9% in patients with chronic rhinosinusitis. In children, the prevalence is definitely lower. So in children with asthma, prevalence may be 1 to 3% just based on the history, but can increase to 5% when they're subject to oral challenge, and it does affect women more than men as well. So kind of the pathogenesis of this disease. So there's one mechanism that kind of causes the aspirin-induced respiratory symptoms. And then there's like another mechanism of like these patients who have chronic inflammation that's present at baseline, even in the absence of exposure to NSAIDs. And these are kind of like hypotheses and postulations of how this happens. But we'll start with the first one of how aspirin and NSAIDs can cause these nasal and respiratory symptoms. So the biggest hypothesis that we have for this is the cyclooxygenase hypothesis. This picture on the left is also taken from the Middleton's chapter. When Dr. Pandya does her board review and goes over this topic, she likes to go through this picture a lot, and she'll kind of test us on all the different enzymes. But the biggest one to note here is really COX-1. So COX-1 is an enzyme that metabolizes arachidonic acid, which is found in cell membranes, and then metabolizes it to prostaglandins here. So aspirin and NSAIDs inhibit COX-1. So if you inhibit COX-1, then you have decreased prostaglandins, and that means you're not producing what we call PGE2. So it's definitely an important one for us to know for boards. PGE2 also inhibits this 5-lipoxygenase pathway. So 5-lipoxygenase is an enzyme that takes arachidonic acid and converts into leukotrienes. So if you have decreased PGE2 from COX-1 inhibition, then you have you won't be able to inhibit this pathway as well. You'll have increased production of leukotrienes, which is what really causes then the symptoms of like the asthma, rhinorrhea, congestion as well. So the pathogenesis of like the chronic inflammation in these patients before they're even like exposed to the aspirin and NSAIDs really goes back to that pathway too. So it's hypothesized that they have baseline abnormalities of the arachidonic acid metabolism. So that metabolite I mentioned, PGE2, reduced generation of that causes more inflammation because PGE2 in itself has anti-inflammatory activity, which inhibits eosinophil chemotaxis and activation and inhibits mast cell degranulation. It's also hypothesized that these patients maybe at baseline just have a local intrinsic defect in PGE2 generation as well. Also, the overproduction of leukotrienes can contribute to chronic inflammation, which again is what I mentioned earlier with the 5-lipoxygenase pathway not being inhibited. And then you also have a decreased production of lipoxin, and that's at the 15-lipoxygenase pathway, which is more up in that chart. So these are kind of the key points, and that's like a lot of cell stuff to know on a molecular level. The key points the board review talks about is knowing that there's increased expression of leukotriene, specifically leukotriene C4 synthase, and enhanced expression of the cis-LT1 receptor. Because you block the COX-1 through these medications, it leads to the overproduction of leukotrienes by the lipoxygenase pathway. LDT4 is what causes the acute bronchoconstriction. And then again, PGE2 is an inhibitor of the 5-lipoxygenase pathways and is decreased by the COX-1 inhibition. So how do we diagnose aspirin-exacerbated respiratory disease? It's really just based on like the history. Of course, everything in allergy is a detailed history. However, in patients who don't have that clear history, you can consider doing a challenge to either confirm or exclude the diagnosis. There are different types of challenge tests, including oral, inhalational, nasal, or intravenous. In the US, we only do oral, but in Europe, they do have guidelines, or I'm sorry, protocols at least for like the inhalation or bronchial challenges. Before doing an oral challenge, you should make sure that asthma is controlled. So patients should have a baseline FEV1 greater than 70% of predicted. And before doing the oral challenge, you would need to withdraw asthma medications. That would include like their SABA, their leukotriene inhibitors if they're on those, antimuscarinic agents, LABAs, things like that. So oral challenge is the gold standard for diagnosis, and we'll kind of go into some of the protocols when we talk about aspirin desensitization. But typically, just kind of like theoretically, you start with the low aspirin dose, typically around 20 milligrams, but it can be lower if the initial reaction is severe, and then you double the dose every few hours or so. After aspirin exposure, the FEV1 is measured before each aspirin dose, and then about 30 minutes to an hour and a half after. These challenges do take maybe up to 2 days, so different than some of our other challenges that we see. And then a persistent decrease in FEV1 greater than or equal to 15% for more than 3 hours is a positive reaction, and it is an indication to stop for the day and then restart and continue the next day. So how do we manage aspirin-exacerbated respiratory disease? So it's really kind of preventing the use of medications that will bring on the disease, so different COX-1 inhibitors, and then giving options for alternative pain medications. So again, this box on the right is from the Middleton chapters. That top group, Group A, are patients who will kind of cross-react to multiple NSAIDs. So again, in the majority of patients, if they have this disease, they will have a reaction to these NSAIDs, but most of them will tolerate other types of NSAIDs, specifically the COX-2 inhibitors. So that's something that you can kind of counsel your patient on, to use selective COX-2 inhibitors. Of course, managing the underlying symptoms as well, with like asthma, chronic rhinosinusitis, and nasal polyps. One thing I wanted to mention that about the Middleton's chapter highlighted too was like in these asthmatic patients, who have aspirin-exacerbated respiratory disease, considering like the use of a leukotriene inhibitor, so like montelukast. Of course, it's like a medication we do use, but I feel like in our typical asthmatic patients, maybe not as much. So in patients who have this, because they have the overproduction of leukotrienes when they're exposed to aspirin or NSAIDs, you could consider montelukast as well. And then, of course, managing their nasal polyps. It did note that these patients are more prone to like surgery because of the nasal polyps. And then, of course, aspirin desensitization is part of the management. So we'll talk about that next. So the protocol, which I'll show on the next slide, does follow. It's pretty similar protocols for aspirin desens and the oral challenge. But once you complete the aspirin desensitization, the typical dose is 650 milligrams twice a day, or 1,300 milligrams daily. If patients are doing well on that dose, you could consider decreasing to 325 milligrams twice daily, or 650 once a day after 1 to 6 months. However, if you go lower than 650 milligrams in one day, there is the chance that they will lose that tolerance and symptoms will return. But once desensitized, the patient does have to take aspirin on a daily basis indefinitely, and if they stop for even 2 to 5 days without aspirin, then that tolerance will disappear. But overall, aspirin desensitization has been shown to improve sense of smell, reduce upper and lower airway symptoms, reduce the number of sinus infections, reduce the need for polyp surgery, hospitalizations, and the requirement for systemic steroids. However, there is a decent amount of patients, up to 20%, who may discontinue daily aspirin treatment due to side effects, typically like gastritis. So this is one example of different aspirin desensitization protocols. This is the one in the board review book. There are multiple like online that you can like look up. So again, we start at a typically lower dose of aspirin and then double it, and takes the span over a few days. I will say, like, another thing the board review book mentioned is that reactions to aspirin during this oral desensitization will typically occur at the lower doses rather than the higher doses. So that's important to know too. So I think that's all I had for the aspirin exacerbated respiratory disease. We'll go on to the other NSAID reaction. So NSAID exacerbated cutaneous disease, NSAID induced urticaria and angioedema. So NSAID exacerbated cutaneous disease is urticaria and angioedema that's worse in patients who already have chronic urticaria and then they're exposed to aspirin and NSAIDs. NSAID-induced urticaria angioedema is acute urticaria or angioedema after exposure to aspirin NSAIDs, but these patients do not have underlying chronic urticaria but may have a history of atopy. Just wanted to make a note that in the board review book, I took a screenshot on the bottom here, but it is written backwards, so especially for like me and Cody studying from the board review book mainly now, just note that they have it flipped around. So the diagnosis of this, so for both of them, because it's going to be urticaria and angioedema symptoms, you want to get the history that these symptoms appeared typically like 1 to 6 hours after drug ingestion. And then the way, again, you differentiate it is if the patient has an underlying history of chronic urticaria or not. But if they've had these urticaria and angioedema after exposure to an aspirin NSAID, then they'll probably have cross-reactivity with all COX-1 inhibitors. You can do an oral challenge for diagnostic testing if the diagnosis is unclear, but typically it's just made through history. Management is mainly avoidance of all cross-reactive NSAIDs, and in patients who have NSAID-exacerbated cutaneous disease, it's really managing their underlying chronic urticaria with like our typical chronic urticaria guidelines with antihistamines, etc. And then aspirin desensitization is typically not recommended for these patients either. So getting on to these last two different reactions. So these are more immunologically mediated. So acute single NSAID-induced urticaria angioedema, and this is what has anaphylaxis. It is an IgE-mediated mechanism, and then the delayed hypersensitivity reaction to NSAIDs is a delayed reaction, and again, that's T-cell mediated. So starting with the acute single NSAID urticaria angioedema anaphylaxis. So again, getting the history for this, so besides just having urticaria angioedema, they will have symptoms more consistent with anaphylaxis. So typically this is like immediately up to about an hour after ingestion, whereas the urticaria angioedema can just be 1 to 6 hours. Some of the, I saw like some of the guidelines say kind of different. Some say that you could do an oral challenge for the causative NSAID, but others also say not to, especially if the history is concerning for anaphylaxis. However, you can do an oral challenge to a chemically unrelated NSAID because in these patients, they should just have the reaction to that single NSAID in the same class of chemical structures, and they should be able to tolerate NSAIDs that are different chemical classes. And then again, aspirin desensitization is not recommended for these patients either. So going into like those different like classes, rather than just like COX-1, COX-2 inhibitors, this kind of breaks it down by chemical class. So for example, say a patient had a reaction to ibuprofen, like an anaphylactic reaction to ibuprofen, that's in the profen chemical class, they could potentially tolerate indomethacin, which is in a different chemical class, even though those are still both COX-1 inhibitors. So I think that's an important distinction between like the other hypersensitivity reactions we talked about. Again, this is pretty readily available online too, that you can look it up. This was also from that same Jackie paper, and I thought it just did a good job of kind of summarizing. So when you have a patient, you're getting the history, it's really kind of classifying, is it just urticaria angioedema, or do they have an anaphylaxis reaction as well? And that also depends on like the onset of reactions. Again, anaphylaxis would happen more quickly, within minutes to an hour, and the urticaria angioedema can be seen even up to 6 hours after ingestion. History of cross-reactivity, so if it's just urticaria angioedema, they will have cross-reactivity to multiple COX-1 inhibitors, but if it's anaphylaxis symptoms, then it would just be to that single NSAID in the chemical class. NSAID exacerbated cutaneous disease will have patients who will have underlying chronic urticaria, NSAID-induced urticaria angioedema, usually no underlying chronic disease, and maybe they have a history of atopy. Yeah, I thought this was at least a nice chart that kind of summarized those things. This was a chart from the Middleton's chapter, so it kind of shows it a little bit differently, and kind of says like how to manage these patients. So if they have a reaction to a single NSAID versus to multiple NSAIDs, doing a challenge. to either that medication they had the reaction with, or if it's a single NSAID, doing the chemically unrelated NSAID to see if they tolerate that. Okay, so the last hypersensitivity reaction is the delayed hypersensitivity reaction. So this will occur at least 6 hours after, but typically it's about 24 hours after, but it can be even within days to weeks. It's pretty similar to, delayed hypersensitivity reactions we think of with other drugs. So like fixed drug eruption, maculopapular eruption, contact photodermatitis, bullous cutaneous reactions such as SJS, TEN, drug-induced hypersensitivity syndrome, so that could be like DRESS, AGEP. I don't want to get too much into these because this could be like a whole lecture on its own, but these are all type 4 hypersensitivity, can even be further classified to like type 4A, B, C, D. And again, we know that we don't do oral challenges for these, especially based on the severity of the reaction. So overall summary, so aspirin-exacerbated respiratory disease, I think knowing that COX-1 inhibition pathway is super important, noting that PGE2 is a big player in that. NSAID, exacerbated cutaneous disease. Patients will typically be cross-reactive to all COX-1 inhibitors, can usually tolerate COX-2, controlling their underlying chronic urticaria, typically not doing aspirin desensitization. NSAID-induced urticaria angioedema, these patients will not have underlying chronic urticaria, and again, avoiding all COX-1 inhibitors, and usually patients can tolerate COX-2. And then aspirin desens is, again, typically not recommended, but could be feasible if avoidance for some reason is not possible, like if they need it for cardiovascular health or whatnot, but again, typically not recommended. And then the single NSAID-induced urticaria, angioedema, or anaphylaxis. So that's the anaphylaxis symptoms from a single NSAID, and you want to avoid NSAIDs in that same chemical class, but the patients can typically tolerate NSAIDs in a different chemical class. Again, the table from that same Jackie article that kind of summarizes it in terms of looking at these 3 types. So the NSAID cutaneous exacerbated disease, NSAID-induced urticaria angioedema, and the single NSAID-induced urticaria angioedema anaphylaxis. Talks about cross-reactivity, which NSAIDs they should avoid, which ones they might be able to tolerate, and if we do aspirin desens or not. So these are my resources, and I think that is all I have.